The physiology of balance and its clinical assessment. Today we focus on the physiology of the inner ear, balance mechanism, and how clinicians put it to the test. Imagine trying to walk a straight line after spinning in a chair. That disorienting feeling is your brain struggling to integrate sensory information. Maintaining balance isn't just about the ear. It requires a triad of inputs: vision, where you are in space, proprioception, feedback from muscles and joints, and most critically, for rapid adjustments, the vestibular system of the inner ear. The balance portion of the inner ear is called the vestibular labyrinth. It sits deep in the temporal bone and contains two distinct types of sensors: otolithic organs for linear motion or gravity, semicircular canals for rotation. The otolithic organs, the linear accelerometers. These are the utricle for horizontal plane and the saccule for vertical plane. Inside each is a gelatinous membrane studded with calcium carbonate crystals called otoconia. When you tilt your head or accelerate in a car, gravity pulls these crystals, bending the hair cells beneath. That bending sends a signal via the vestibulo-ocular nerve to the brain. The semicircular canals, the angular accelerometers. There are three canals: lateral or horizontal, anterior or superior, and posterior, each oriented in a different plane of space. They detect rotation, for example, shaking your head no or tilting it ear to shoulder. Inside each canal is fluid called endolymph. When you turn your head, the canal moves, but the fluid lags behind due to inertia. This pushes against a flap called the cupula, bending hair cells. Importantly, the canals work in a push-pull mechanisms. When one side is excited, the opposite side is inhibited. This asymmetry is what your brain interprets as rotation. Central pathways from ear to brain. Signals from hair cells travel along 8th cranial nerve to the vestibular nuclear complex in the brainstem. From here, information diverges along 4 critical pathways: to the spinal cord through vestibulospinal tract, which adjusts extensor muscle tone to keep you upright; to the cerebellum, which fine-tunes balance and coordinates movements; to the thalamus and cortex for conscious perception of dizziness or motion; to the eyes through medial longitudinal fasciculus, which generates the vestibulo-ocular reflex. This keeps your vision stable when your head moves. For example, nod your head yes, but keep staring at a fixed point. That's the vestibulo-ocular reflex. That is why a lesion anywhere in this pathway, ear, nerve, or brainstem, produces vertigo, nystagmus, and ataxia. Clinical tests of balance mechanism. How do we test this complex system at the bedside? Here are 5 essential clinical tests ranging from screening to specific. These are Romberg's test, head impulse test, Dix-Hallpike maneuver, Unterberger's stepping test, and dynamic visual acuity. Test 1. Romberg's test. It is used basically for screening of sensory ataxia. Patient stands feet together, arms crossed, eyes open then closed. Minimal sway is normal. If they fall only when eyes close, that suggests loss of proprioception, for example, neuropathy. But if they are unstable even with eyes open, suspect vestibular or cerebellar issue. Test 2. Head impulse test. It is used to test vestibulo-ocular reflex integrity. Patient stares at your nose. You gently but rapidly turn their head 10 to 20 degrees to one side. Their eyes stay locked on your nose. Vestibulo-ocular reflex works. If there is an abnormality, there will be a catch-up saccade. Their eyes are dragged off the target, then they snap back. This indicates peripheral vestibular weakness on the side you turn toward. Test 3. Dix-Hallpike maneuver. It is the gold standard for benign paroxysmal positional vertigo. Sit patient on exam table, head turned 45 degrees to one side. Rapidly lie them back so head hangs 20 degrees below horizontal. Observe eyes for nystagmus. After a 5 to 10 second latency, you see upbeating and torsional nystagmus that fatigues. This confirms benign paroxysmal positional vertigo which occurs due to loose otoconia in the posterior canal. Test 4, Unterberger's or Fukuda's stepping test. In this test, the patient closes eyes and marches in place for 50 steps. If they rotate more than 30 degrees to one side, that suggests a peripheral vestibular lesion on the side they turn toward. Test 5, Dynamic Visual Acuity. In this case, test visual acuity while patient's head is still, then while examiner passively oscillates their head at 2 Hz. A drop of more than 3 lines on the eye chart during head movement indicates a bilateral vestibulo-ocular reflex loss, for example, ototoxicity. If a patient has acute vertigo with nystagmus that is suppressed by visual fixation and a positive head impulse test, think peripheral cause, for example, labyrinthitis. If the head impulse is normal and there are other neurological signs, for example, dysarthria, think central cause, for example, stroke, which is a medical emergency. So testing the balance mechanism is not just about spinning patients. It's about localizing lesions from the otoconia to the brainstem. To recap, the otoliths sense gravity and linear motion, the canals sense rotation. The brain integrates these signals via the VOR and vestibulospinal tracts. Thank you for watching. Don't forget to like, subscribe and hit the bell for more neurophysiology content.